Hello everyone, welcome back. Today I'll be covering Genu virus in children, a simplified version. Started off with an introduction, physiologic bow leg, pathologic bow leg, Blount disease, especially infantile Blounts, Lagenskiold Classification, clinical features of differential diagnosis, blood investigation, radiological investigation, and lastly, management. This figure shows a bow-leg children who has an increase in the intramellular distance. Now, let's get started. As an introduction, bowing deformity of the lower limbs is commonly seen in children in the first years of life. Bow legs genovarum is an angular deformity at the knee where the apex of the deformity points away from the midline. Differential diagnosis of bow legs in children between age 1 to 3 years are physiologic and pathologic conditions. For physiologic bow legs, is a consequence of normal growth and development in both the coronal and transverse planes. Children present with obvious bow legs around 2 years old, followed by knock knee at the age of 2 to 3 years. Then, develop slightly valgus knee similar to normal alignment of the lower extremity in adults by the age 6 to 7 years. This figure illustrates the physiologic bow legs. During 0 to 18 months, children usually has a bow leg, and usually at the 18 to 30 months would be slightly corrected. And then at the age of 3 to 4 years, there will be a knock knee, and at 8 to 10 years, it will become normal. Pathologic bowing of the lower extremity. Most common causes include infantile tibia vera or Blount's disease. Other causes include vitamin D or calcium deficient rickets due to dietary clause, persistent physiologic varus, renal osteodystrophy, vitamin D resistant rickets, focal fibrocartilaginous defects of the proximal tibial metaphysis, skeletal dysplasia, osteogenesis imperfecta (OI). Blount's disease is an acquired asymmetrical growth disorder of the proximal medial tibial physis and epiphysis, or a growth plate disorder of the medial aspect of the proximal tibial physis, which results in a progressive genovarum deformity of the lower extremities. This condition described by Blount in 1935. This condition was also referred as Blount's disease. Blount disease exists as two clinical variants: infantile or early onset, adolescent or late onset. It is defined based on whether the first manifestation developed before or after 10 years of age. These two clinical forms that is distinguished based on the age of onset, so they require different treatment strategies. for infantile Blount's disease is typically seen in children between the age of 2 to 5 years old. It is characterized by varus deformity of the proximal tibia in an otherwise healthy child. Bilateral involvement in 50% of the cases, and boys are affected more than girls. The etiology of infantile Blount's disease remains unknown. Deceleration of growth occurs at the posteromedial area of proximal tibial physis, which results in varus, flexion, and internal rotational deformity. Histologic study of the affected physis has shown disruption of normal columnar architecture of the physis. Fibrous tissue replace the physeal cartilage and osseous bridging between the epiphysis and metaphysis in severe case. Definitive diagnosis of Blount's disease is based on the progressive clinical bow legs with the presence of characteristic radiographic changes of proximal and medial tibial physis as described by Lagenskiold. In 1964, Lagenskiold and Rickets proposed a radiographic classification based on 6 progressive stages of the infantile type of Blount's disease. These are widely used to determine disease prognosis. They stated that spontaneous correction often occurs in patients with stage 2 lesions and occasionally in those stage 4 lesions. Regarding Lagenskiold classification, the figure there shows the classification from type 1 to type 6. It is based on a cascade of different degrees of epiphyseal depression and metaphyseal fragmentation of the proximal medial tibial epiphysis. 1. Irregular metaphyseal ossification combined with medial and distal protrusion of the metaphysis. 2, 3, 4 evolved from a mild depression of the medial metaphysis to a step-off of the medial metaphysis. Number 5, increased slope of medial articular surface and a cleft separating the medial and lateral epicondyle. And finally, 6, there is bony bridges across the physis. Regarding clinical features for differential diagnosis, in physiological bowing, there will be a common torsional condition secondary to normal in utero positioning. Spontaneous resolution with normal growth and development occur. Clinical features in Rickets. Generally, there is a failure to thrive, malnourished patient. There will be a protruding abdomen, muscle weakness, especially proximal, fractures, the head, especially a frontal bossing, delayed frontal closure, craniosynostosis, the chest rachitic rosary present, the back scoliosis, kyphosis, lordosis. There is an enlargement of the wrists and ankles, and windswept deformity will be seen. Anterior bowing of the tibia and femur. leg pain. For Blount disease, among the clinical features, Blount disease is an abnormal endochondral ossification of the middle aspect of the proximal tibia physis leading to varus angulation of the tibia. Infantile form is the most common, bilateral with prominent medial metaphyseal beak, internal tibial torsion, and leg length discrepancy. Adolescent form, normal or greater than normal height, no palpable proximal medial metaphyseal beak, minimal internal tibial torsion, mild medial collateral ligament laxity, and mild limb length discrepancy. So next, regarding blood investigation, we can order a serum vitamin D3, serum phosphorus, alkaline phosphatase in the liver function test, the calcium level, renal workout throughout renal osteodystrophy, infective marker throughout infective causes for the bow leg. Radiological investigation, full-length scanogram, physial bar mapping on MRI for physial injuries. A standard anteroposterior and lateral radiograph of the knee are obtained first. In early stage of infantile Blount disease, they show medial varus malalignment of the tibial metaphysis, delayed medial ossification, broadening and contour irregularity of the medial metaphysis, producing a beak-like protuberance. Many angles have been described. The useful are the mechanical tibiofemoral angle, metaphyseal deficit angle MDA, and bony tibial slope. MDA more than 16 degree are significantly abnormal. This X-ray shows a full-length scanogram or whole lower limb profiling. We can see the medial metaphyseal deficit angle is carried out in the X-ray. Regarding treatment. Number 1, medical treatment mainly for vitamin D deficiency rickets, hypophosphatemic rickets, renal osteodystrophy. Number 2, bracing. It has limited role. In the Blount disease, a 3-point brace customized as per child that can be used to correct the deformity. Number 3, surgical management. There is 2 options. In a skeletally immature children with at least 2 years of growth left, can be treated with growth modulation, that means hemiepiphysiodesis, while the skeletally mature children with closed or fused growth plates requiring osteotomy and fixation. Yay, we have reached to the end of this video. See you in the next one. Take care and bye.